Thank you for the invitation to speak here and bring you greetings from the great state of South Dakota, which you'll recognize here on the figure. Let's move ahead here. In the, 2010 guidelines, one of the unanswered questions was, do omega-3 fatty acids, excuse me, yeah, that's what we need, reduce risk for cardiovascular disease based on evidence from randomized controlled trials and from prospective observational studies in patients with or without CVD and using omega-3s from plants versus marine. So that's a lot. It's a big question. A lot of studies have been spawned asking those questions. And we'll look at some of them today. It's still a confusing area. What do we know? We know that most epidemiologic studies support a beneficial role of omega-3 fatty acids. And primarily I'm talking about EPA, DHA, the marine, although there's evidence for ALA too. But unmeasured confounding could still be important. It's always a problem with prospective cohort studies, so there's a weakness there. We know that the early randomized trials with omega-3 were successful, sometimes fabulously successful. Later ones have not been successful, so what happened? We'll look at that. We'll look at the question of whether you measure an omega-3 biomarker, here the omega-3 index, which I'll discuss in a moment. Will that help us get away from food frequency questionnaires and look at true omega-3 status? And then we need to gather the right evidence for omega-3, that's for sure. So the omega-3 index, illustrated here, is simply a measure of the amount of EPA and DHA in red blood cell membranes. And it's expressed as a percent of the total fatty acids. In this cartoon of a red cell, if you cut away the membrane, the outer and the inner phospholipid bilayer, here there's 1, 2, 3 omega-3 fatty acid, EPA or DHA, and the others are non-omega-3s. So in this cartoon, 64 fatty acids, 3 of them are omega-3, 3 out of 64 is 4.6%. So that's a simple way of understanding what the omega-3 index would be. That's very typical. If you could look at the red blood cell of a typical American, you'd see an omega-3 index of about that, 4 to 5%. Is the omega-3 index a valid marker of intake of omega-3 fatty acids? Well, yes, it is. We've looked at it in a variety of ways. A study we published several years ago looked at the relationship between oily fish, reported intake of oily fish, and with or without fish oil capsule use. And without being able to see the bottom line here, the taller bars are the people that are saying, yes, I'm taking fish oil supplements, more and more and more supplements, and the bottom, the smaller bars are increasing reported intake of oily fish. And so this is the omega-3 index on this axis. As the reported fish intake goes up, the index goes up. As you take supplements, you get about a 2 percentage point increase without even knowing how much supplement. Some other evidence, a study, dose-response study done by Dr. Flock here from Penn State. We were participating in that as well. In this study, a 5-month treatment with either a placebo, 300 milligrams of EPA DHA, 600, 900, or 1,800 milligrams a day, showed a very nice rise for dose-response related rise in the omega-3 index as a function of EPA and DHA intake. So it is a good marker of intake that's been validated in a variety of ways. Now comparing the use of a marker, I just picked one study to compare the use of a dietary intake questionnaire versus a biomarker. Here, this is for incident diabetes and a prospective study from Virtanen and their group in Finland. Here they looked at omega-3 fatty acid exposure in 2 ways. Here, based on a food frequency questionnaire of intake, long-chain N3 fatty acid intake, and then at risk across the quartiles of intake for incident diabetes. This was not statistically significant when they used long-chain fatty acid intake, but when they used serum, in this case, serum long-chain omega-3 fatty acids, they got a statistically significant relationship. So here, dietary intake was not as sensitive, at least as a marker of incident diabetes, as the dietary intake was. So using a biomarker can certainly help clarify the relationship between the nutrient and the disease. This is also a point I want to make here. Different endpoints, you get different conclusions. Data from Dr. Mozaffarian, who was here at Tufts, they looked at about 2,700 older individuals, 74 years of age at the beginning of this observational study. This is a cardiovascular health study, followed for 16 years for different endpoints. And as a function of, I've calculated what the red blood cell omega-3 index would have been, and here the red is the lowest quartile at about 3%. The whatever color that is 5.6%, the highest quartile. So across the quartiles of omega-3, they looked here in this particular study at total mortality and found a significant relationship. The higher the omega-3 level, the lower the risk for mortality. Cardiovascular disease mortality was also significantly reduced. Arrhythmic cardiovascular heart disease, despite this one, there was still a strong relationship between higher omega-3 levels and reduced risk for dying from cardiovascular disease. But if you look at a different endpoint, non-fatal MI, non-fatal heart attack, a heart attack that was survived, there was not a significant relationship. And this has been seen many times. The omega-3s appear to have benefits on fatal endpoints, but not on heart attacks per se. And so if you pick the endpoint of non-fatal MI as your endpoint of interest, you may say there's no relationship with omega-3. If you pick total cardiovascular events or arrhythmic disease, you might see an effect. So many of these big studies, big epi studies, will do combined endpoints, where they put all these different cardiovascular endpoints together, some of which may be affected by the agent of interest, some of which may not be affected. And you can dilute out and lose all the significance that may be related to a specific endpoint if you just had enough power to measure it. Most recent meta-analysis in this field, of course, we love meta-analyses. Chowdhury and colleagues published in Annals of Internal Medicine last year, a tome of fatty acids and heart disease across all fatty acids. This looked at a meta-analysis looking at dietary intake of fatty acids and coronary outcomes. The number in parentheses tell you how many studies were considered for, is there a relationship between saturated fat and cardiovascular outcomes? No, 20 studies. No, meaning it was not significantly different from one. Relative risk was not different. Monounsaturates, not related. ALA, not related. Long-chain omega-3 fatty acids were a significant reduction. The higher the intake of long-chain omega-3 from 16 studies, the lower the risk of cardiovascular disease. There was no effect of omega-6 PUFA, and there was a significant increased association between dietary intake of trans fats and cardiovascular disease. So the only two significant ones were omega-3 beneficial, trans fats harmful for dietary intake. They also looked at studies that reported circulating levels, so now we're into biomarkers. And in circulating fatty acids, the only ones that were significant are, now I've broken them down to individual fatty acids. EPA and DHA, and EPA plus DHA, so that would be sort of the omega-3 index, were all significantly associated, a higher level of those in the circulating compartment, whether it's red cells or plasma phospholipids or whole blood. Didn't make a difference. They were all significantly related to reduced risk. Even DPA-N3, which is the intermediate fatty acid between EPA and DHA, higher levels of it were associated with reduced risk. Linoleic acid was not significant, it was slightly lower. This is interesting regarding Dr. Frisch's talk. Arachidonic acid levels in the blood measured in 10 studies. There was the higher the arachidonic acid level, the lower the risk for cardiovascular disease in this study, and that was statistically significant. So if arachidonate is the precursor of all these bad or pro-inflammatory markers, why is having a higher arachidonic acid level associated with less cardiovascular disease? So this again argues that the omega-6 is bad argument, I think, is a little weak. Now, one of the issues, of course, in observational studies is control of confounders. And I want to drill down into this for a minute because we've just done a study, I'll show you the results from it, that have kind of shaken me to the core. as to whether I really believe omega-3 epi studies or not. Let's just read what the definition of this is. Several aspects of a substance-disease relationship may give rise to confounders. Therefore, it's important to adjust for confounders of the disease of interest so that observed effects on risk of disease may be due to the confounders are not incorrectly attributed to the substance of interest. So again, a confounder is something that's related both to the nutrient and to the disease, but it's really not part of the causal pathway. The question is there really a relationship between the nutrient and the disease? So here's a study. We have not published this yet. It's submitted that, as I mentioned, gave me serious pause. So the question we looked at in this study was, are patients who start fish oil supplementation within the first month after they have a heart attack, obviously survive the heart attack, different in some way from patients who don't start taking fish oil? So we looked at, in this study, 377 post-MI patients who were not taking fish oil at admission, but when we asked them at 1 month after admission, are you taking fish oil now? They said yes. So they were the ones that started fish oil supplementation. Another 2,000 of them, when asked, had not started fish oil supplementation. We don't know why they started. We can't ask them. We didn't ask them that. They could have been told by their doctor. They could have read it in a magazine. They just decided to start fish oil supplementation. So the question is, are those people any different than the people that started fish oil, any different than people that don't? Because if there are major differences between those two, then maybe future outcomes are related to those differences, not to the fact they're taking the omega-3. So here's what we found. Fish oil starters were more likely to be financially secure, to be married, more likely to be male, more likely to have insurance, more likely to have had a post-high school education, more likely to be on a statin at discharge, more likely to have had angioplasty, acute angioplasty during their event, more likely to have participated in cardiac rehab after their event. They had a better LV ejection fraction. They had a lower HDL and a higher triglyceride level, which kind of goes the opposite direction. They were in better physical condition. So all those factors, none of which you really can imagine the person who started fish oil knew that they felt like that, or had, I had angioplasty when I went into the hospital, therefore I had to take fish oil. It doesn't make any sense. But these are all differences that we observed with these people. Fish oil starters were also less likely to have a history of angina, to have a history of previous MI, to have had cabbage, to have had a previous stroke, to abuse alcohol, to have had diabetes, chronic kidney disease. So in this study, a small study admittedly, there are many differences between people who chose, for one reason or another, to increase their omega-3 intake after they were discharged from the hospital, from those who didn't. And so if we look downstream and say, well, there are different health outcomes in those two groups, can we attribute it to the fact that they actually took fish oil? And can we really control for all these confounders? Many of these things you never are not asked for or not included as confounders in the observational studies that are typically published. So here's the thing that scares me. We then looked at the association between fish oil supplementation, starting fish oil, and 2-year mortality in these patients. So who's dead and who's alive 2 years later? What we found was if you look at the unadjusted model, where it's just started fish oil or didn't start fish oil. Those people who started fish oil were, so the relative risk 0.45, 55% less likely to be dead. So there was a protective effect of being a person who started fish oil after the MI. If you add demographic variables in, then the relative risk starts to move toward this magic line of 1. You have SES factors, it moves a little closer, but we still have the little happy faces, meaning it's still significant and there's still a benefit. Once we hit add disease severity factors, we start going over the line, we get a little questionable face, then we add treatments, then we add health status, and all of a sudden there is no significant reduction in risk for death in 2 years in people who started fish oil who didn't. If you only looked up here, or if you stopped right here, you could publish a nice paper. But if you keep going and keep adding more and more, I mean, people are very aware that the more variables you add, the less significance you find typically. And this is a graphic example of that. So I don't know if all these epidemiologic studies that show higher omega-3 levels either in the diet or in the blood are really pointing to an effective omega-3, or they're talking about omega-3 as a marker of a certain kind of person who eats a certain way, who lives a certain way, has a lifestyle that is just more healthy. And it's going to be very difficult to untangle that. This is an imperfection in observational studies. Randomized trials have their imperfections too, as we all know. And we're not going to go through all this, but these are, if you just focus here on this column, these are the trials, the major randomized trials in the omega-3 space starting back in 1989. Some of them get little green faces, happy faces, because they were significant. One popped up here negative. Actually, the only red one here is that there was an adverse effect in one subgroup of omega-3 in the DART-2 study. But up to about 2008, we had fundamentally lots of good data. DART, 2 GISI studies, the JELIS study, the largest trial of omega-3 ever been done, were all significant. And this is what sort of laid the foundation for most recommendations for omega-3. Then we start in 2010, and we hit a real spate of studies that this is a neutral outcome, meaning there's no adverse effect, no beneficial effect, just no effect, no relationship. 1, 2, 3, 4, 5, bang, 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 and all of them showed no effect of omega-3 up until 2013. And so what happened? A lot of reasons, a lot of things to think about. People have considered what's going on here. Of course, this is meta-analyses. Every time there's another study done, another meta-analysis comes out. So these are, since 2002, these are the meta-analyses that have come out. Actually, there's been 4 of them in 2012 came out. And as you can see, they're fundamentally green, happy studies until we get up into Chen here, then green, not good, green, not good. This is the one I want to focus on, the bottom one. Study by Rizos, a meta-analysis published in JAMA September of 2012. The one that probably got the most news. It was on all the major news outlets. So here was the title, Association Between Omega-3 Fatty Acid Supplementation and Risk for Major Cardiovascular Disease Events. Systematic review, major meta-analysis. I'll pull out the conclusion here, which is right here. Overall, omega-3 PUFA supplementation was not associated with lower risk of all-cause mortality, cardiac death, sudden death, MI, or stroke. That's the bottom line. It's useless. And some very influential cardiologists went on on record as saying the fish oil story is dead. Well, let's look at this meta-analysis that Rizos did and how they, and a sneaky statistical game that they played, in my view. So this is the table that shows the final results. So here's the outcome of total mortality, all-cause mortality. 17 studies were reviewed. Here is the relative risk and the confidence interval, and it's illustrated graphically over here. 0.96, a 4% reduction in risk, but it crossed the 95% confidence interval, crosses 1, so it's not statistically significant. Fair enough. You get down to the next one, cardiac death. 13 studies with cardiac death as an endpoint. 0.919% reduction in risk, and it's statistically significant. You can see it here, you can see it here. So using the standard statistical test that we use in meta-analyses, which is a 95% confidence interval, that was significantly reduced. Sudden death, myocardial infarction, stroke, none of these were significant. So how did they get to their conclusion that there was no benefit? Well, here's how they do it. This should have been the conclusion. They decided to set the critical level not at 0.05, but 0.006 in a meta-analysis, of all places, to what they say control for multiple comparisons. This has never been done. I looked at 15 other meta-analyses published in JAMA that year in 2012, and not one of them used anything but a 0.05. But in any event, when they did this, all of a sudden the confidence interval crosses 1 and it becomes a non-significant effect, and their conclusion is, in their opinion, omega-3 fatty acids have no effect on cardiac death. And that's simply a statistical maneuver that made that happen. I don't know why they did that, but it's certainly unusual in the meta-analysis world. So where do we stand today? Fish oils may not work, whatever that means, in certain settings. And these are basically taken out of these meta-analyses. In patients who have dysglycemia, a history of heart disease, recent MI, in patients who are also in their early 60s, in patients who are given only, and this is sort of the range of omega-3 that's been used, 380 to 1,000 milligrams a day. Very importantly, in people who are treated for only 2 to 4 years, typically, that was sort of the range in these studies, who are consuming omega-3 fatty acids in their background diet at higher levels than typical of the American diet, partly because the omega-3 message is getting out that people should eat more. So the control groups are eating fairly high amounts of omega-3. Nobody's measuring any omega-3 biostatus to know if the people who had the lowest omega-3 levels got the best benefit. And also very important, the more modern studies, 2010, 2011, and 2012, patients are all being treated with background drugs, statins, ACE inhibitors, aspirin, beta blockers, and the omega-3 then has to do better than all of that. And it's very difficult to improve in that context with 1 gram of omega-3. But this is basically the way pharmaceutical trials are done. You take a group of high-risk people, you give them what they consider a big dose. This is not a big dose of omega-3. You follow them for 2 to 5 years, and then you count bodies, you count your endpoints. And that's not a nutritional model. We don't consider starting people in omega-3 when they're 60 to 65 years old and asked it to do the job of correcting 65 years of abuse. Fish oils are still likely to work, in my view, in people who don't already have subclinical cardiovascular disease, people who take omega-3 supplements or eat high omega-3 diet. They don't have to be supplements, but they can eat higher omega-3 levels for decades, maybe their entire life, maybe since -9 months, which would be a great place to start, who take higher doses of omega-3, who actually have a low omega-3 index that might need to be treated, who are not on optimal drug therapy or are not optimally compliant. That's much more common the case in the real world. People are just not compliant with their treatments. So I think there's a lot to learn. In summary, how do we get the right evidence for an omega-3 claim? Well, here's one way you do it, but this is the chances of it ever getting done. We randomize 20,000 people who are in their 30s, give them 1 to 2 grams a day and follow them for 30 or 40 years. Well, who's going to do that? Nobody's going to do that. So that's the evidence you really need. So given that fact, we're dealing with difficulties in the randomized controlled trial space. We're dealing with difficulties in the observational studies that we just have to live with. And we just have to use our best judgment. And speaking of the toxicology and what's the risk here involved, the risk for taking omega-3 is essentially 0. So any potential benefit, in my view, ought to be considered to produce a favorable risk-benefit ratio. I think it would be helpful to design studies for use patients who have a low omega-3 index and then show that if you titrate to a certain level of omega-3 index, you don't just give 1 dose of omega-3, and see if you can get over a certain omega-3 index. Say, try to achieve the Japanese level of omega-3 and see what happens. That will take a serious dose. So at the end, follow guidelines that we've outlined here earlier, checklist in the design phase, know where you're going. These trials are going to be hard to do, but we need to start with that. And here is the view from Wyoming, okay?